started.
Cool. So I have the pleasure of introducing Hannah Deming today. She is one of our fantastic palliative care fellows in the pediatric track. And Hannah was a resident here at Children's and then completed her chief year and has been with us this year. And it has just been an absolute joy to get to know her and a privilege to work with her and learn from her. And this talk I have got to see in different phases, and it's just really wonderful. And I'm so excited that she has an opportunity to share it with you today. So, Hannah, we're so excited for your talk.
Thank you. Thank you, everybody. I appreciate everyone coming. And this really, despite being virtual and with slides, I would love for this to be conversational. So please feel free to interject with questions or comments at any point. So I first want to start with a land acknowledgement that at least I realize that different people are in different places. I'm on the traditional land of the Duwamish people, the first people of Seattle, past and present. I express my gratitude for this land itself and honor the ancient heritage of the Duwamish people who continue to be with us today. And I encourage people, especially those in the Seattle area, to consider contributing to Real Rent Duwamish as a way of acknowledging our respect. So quickly, where we're going to cover for this talk is some background on where are we at in terms of providing palliative care for people who speak languages other than English. What are some of the particular challenges in providing palliative care to people who speak a language other than English that make it important to think about how we work with interpreters in this field specifically? What are some of the best practices that are known in the literature? Where are we going, in my view, for the future in order to be better? And then, of course, I'd love to have discussion. And like I said at the start, as much as I've tried to save time at the end for discussion, I'd also love to have it as we go. I know there's a lot of experience in this room or this virtual room, and would love to hear everybody's input. So first, for our background. Oh, and I have the chat also open on my phone, so please feel free to put things in there, and I should see it, but if I also don't, just someone call out. So first off, in terms of terminology, I'll be using the term language other than English, which I'll be abbreviating as LOE. This is a terminology that was established with feedback from interested parties, particularly at Seattle Children's Hospital, and it leads away from the deficit model that is inherent in limited English proficiency and is more highlighting strengths. And it also moves away from a language you've potentially heard elsewhere of language preference, given language is not a preference, it is a need and a skill. So why focus on interpretation and palliative care? I became particularly interested in this topic this year when I was having a series of cases and I felt like I was particularly struggling and working with interpreters. And it sort of struck me around that time that out of no fault of any particular person or program or hospital, but just kind of where the field is at, and honestly, just the healthcare system and society at large, that I haven't had any particular training throughout my medical training in working with interpreters and how that odd that is, especially as I move on to try and be a communication expert. And we are really fortunate in this country and in this region to have a lot of linguistic diversity, although we also know that families who speak languages other than English experience disparities in palliative and end-of-life care. There's a lot of literature showing that they have higher rates of uncontrolled pain, as well as broader end-of-life symptom control challenges, lower understanding of their clinical situation. They face differences in communication from their clinical team, and likely due to the combination of these factors and others, increased family stress about their loved one's clinical situation. And so in one of these studies that was a qualitative study and did interviews with English-speaking families and non-English-speaking families who have children that were getting palliative care, found that the families who spoke a language other than English were more likely to share that they had gotten no information or partial information or false reassurance regarding their child's healthcare, and that this had resulted in acute and long-lasting distress and dissatisfaction with care, which I think is just so powerfully captured by this quote from a father of a child who spoke a language other than English, where he says, "Since their language is different from ours, that made me feel impotent, also fearful. Fear was always there." And in a landmark study that Dr. Randy Curtis was a part of, there was less emotional support provided to families in interpreted care conferences throughout kind of our UW system, with the mean attempts per care conference to ease the burden on a family of basically none if the care conference was interpreted, compared to a couple attempts if the family was English speaking. Fortunately, in a recent study that was performed at Seattle Children's a few years ago, this was not replicated, which is providing some hope that maybe we are getting a bit better at providing empathetic statements in our work with interpreters for families who speak a language other than English. And it's like one of the interesting things that I just noticed when I was looking through the two studies is that there are some signs that we have some different practices when we're working with interpreters now than we used to. So in the initial study that again was with adults, and what the data was collected between 2000 and 2002, interpreted care conferences were actually shorter than those that occurred in English, which the authors note likely means that even just like less medical information was shared with the family, given the time impacts of interpretation especially. And then in this most recent pediatric study in a couple of years ago, the interpreted care conference was significantly longer than the one from the older study, as well as compared to English speaking care conferences more recently. So suggesting that we have potentially made some progress in terms of our communication practices, though I think it still leaves open the question of how long should an interpreted care conference be relative to an English care conference, since the language communication generally takes about twice as long, but it's something I keep pondering about. And then we also have studies that show that in PICU, so pediatric ICU care conferences, LOE families are generally speaking less than their English counterparts, with the provider to family talking ratio being about 2.2 to 1 for English speaking families compared to 4 to 1 for Spanish speaking families. So suggesting that within the time of those care conferences, we, the providers, are also taking up a lot more of that communication time compared to the families when we're working with an interpreter than when we're not. And interpreters are telling us also that we're not doing a very good job with these conversations. In a survey of over 100 medical interpreters in the United States regarding end-of-life discussions, 52% said that these conversations, when interpreted, usually do not go well. 76% said that interpreting these conversations was more stressful than interpreting other talks. And about a similar percentage, about 72%, said that they found these conversations, these end-of-life conversations, less satisfying to interpret as well. And I think it's also important to note that about really just 0% of interpreters in these surveys have ever received formal training in palliative care or end-of-life conversations. And so what are some of the challenges in terms of palliative care conversations for interpretation and especially for interpreters to navigate? First off, the literature shows that we use a very high rate of challenging vocabulary in end-of-life discussions. So in the same survey I referred to earlier, about 80% of interpreters said that they commonly saw technical terms used with the sharing of bad news or prognosis planning, and a similar percentage when the conversation was regarding withdrawal of treatment. And what kind of remarkably is that we're managing as providers to use technical terms in 47% of conversations that are like a death notification. So really just highlighting this habit we have of using technical and complicated words. And many medical words do not have equivalents in other languages. So one of the examples I heard most commonly from interpreters I spoke to, as well as in the literature, is the word hospice, which when literally interpreted in Spanish, or verbatim interpretation becomes hospicio. However, hospicio typically conjures in the mind of many Spanish speakers an orphanage where poor people are left to die. So certainly not what we are intending to refer to when we talk about a hospice. And then I think it's also just important to remember that many medical terms, including like words like MRI, do not have an equivalent term in other languages. The other challenge for interpreters in these conversations is that palliative conversations or end-of-life conversations are notorious for leading to people using indirect communication styles and metaphors and referring to abstract concepts. And these are hard conversations for people to understand who are native English speakers. But then if you imagine trying to understand what the provider is kind of saying in a beat around the bush way, and then to be able to interpret it, you can imagine how, like, that's just a next level of difficulty. And interpreters recognize that these are really important and high stakes conversations. So this is a quote from Julie Green, who was or may still be, an American Sign Language interpreter at the University of Washington Medical Center, where she's referring to the experience of interpreting the words of a priest administering last rites and the pressure of making sure that her words were chosen correctly. And also just like the broader import she recognizes her work has of, I must remember that my role is that of a communication facilitator, and to ensure that our patients have equal access to care by bridging the communication gap. And so really just recognizing the importance of these conversations and her role in them in general makes these conversations particularly stressful for them to interpret as they try to be perfect. And the end-of-life discussions have short and long-term emotional impacts on our interpreters, just like they do on the rest of us. So in that survey of healthcare interpreters, over 50% felt emotionally overwhelmed while interpreting the sharing of bad news or withdrawal of treatment. And over 80% were thinking about these conversations afterwards. And I think this quote by Julie Green kind of also gets at some of the emotional impact interpretation in these contexts has. She talks to us about, it's a very difficult to be the bearer of bad news. Even when the words are not mine, I am still the messenger. And she reminds us about how interpreters work with the same family often over sometimes multiple years, and the bond that develops for the interpreters with patients through that experience. And then she also talks about it's challenging not to internalize the emotional magnitude of knowing a patient is dying. And this quote also like reminded me of one of my co-fellows. She went to the funeral for a patient whose family was Spanish speaking, and she was sharing with me that the like most represented group from Seattle Children's Hospital was actually the Spanish interpreters. And so just the bond and ties that our interpreters feel to our families is really strong. Additionally, hard conversations are notorious for having sensitive content. They feature topics that there's often cultural, family, and individual norms around how these things are supposed to or not supposed to be discussed. So there's opinions on how hard news should be conveyed and who should be told hard news. And of course, these dynamics are present also with English-speaking families. However, with an interpreter, when we're working with them, they also have their individual perspectives on how these things should be communicated that also weighs into how they're viewing the conversation. And most interpreters report feeling like they've been asked to interpret things that conflicted with the patient's culture, with 68% feeling that way with the sharing of bad news, and 58% when talking about withdrawal of treatment. And unfortunately, the survey wasn't designed to be able to get at specific examples of how this has occurred for interpreters, but I can imagine, especially in light of the prior quote, in terms of interpreters feeling like they are the voice of these messages, that this could lead to a lot of moral distress, to feel like you're being asked to say something to a person or a family that you believe is in conflict with their culture or their values. And so what are some best practices from here? How do we do better? the number one thing is to use a professional. And I'll acknowledge, like, in trying to keep this talk tight and short, I've like repeatedly kind of wanted to like take this piece out, because it sort of feels like the like obvious piece that we've all heard many times before. And at the same time, I think that in my personal experience and in the literature, it just continues to show that though we know that using a professional is important, there are many barriers that get in the way and make that hard for us to do. And so it continues to be probably the most important and the lowest hanging fruit in terms of us doing better. So I think a lot of when you look at the literature, the problems with using family as an interpreter instead is overall lower patient satisfaction, reports of it being emotionally burdensome on the family, heightened emotions and personal beliefs also threaten accuracy when using a family as an interpreter for end-of-life conversations and palliative conversations especially. And even just in general, we know that professional interpreters reduce errors in communication, where in one study, the odds ratio of a communication error of potential clinical significance occurring with an ad hoc or like family interpreter was 2.2 when compared to a professional interpreter, and really wasn't much different than using no interpreter at all. And this was, these studies were kind of like across all like all conversation topics. So you can also imagine that likely the rate of clinically significant communication errors occurring is even higher when it's regarding such emotional and sensitive topics and complicated topics as palliative care conversations. And so like real world, I'd love to get people's input either in the chat or out loud about what are some of the strategies you have found successful at your site for being able to access interpreters more easily. So I'll just like say at Seattle Children's, it's really important and helpful to pre-schedule interpretation, and we're able to do that days to weeks in advance. But especially at Seattle Children's, we use a lot of agency or per diem interpreters. So getting them booked ahead of time is really, really important. And I'm just curious if there's anything else people have found helps them be able to get a professional interpreter when they need them. I see Kira says having access to more in-person interpretation rather than just telephonic. Absolutely. In-person is so much better. I completely agree. And that's one of the things I have found helpful in trying to also prioritize in-person interpretation is with this pre-scheduling is to then have that person or an in-person interpreter come every day and like plan that for, and especially when a patient is expected to be in the hospital for a while. So that way I have like an appointment with the family and the patient and the interpreter to provide a more thorough update every day, in addition to like telephonic interpreters for some more as needed, shorter updates. Any other suggestions before we move on? Oh, Melissa, scheduling is super key, and we need to build up our systems to streamline advanced scheduling for the coming days when there is a known consistent need. I completely agree. And then Nosley also adds using cultural mediators who have more familiarity with our team and the types of conversations we have. Also pre-meeting with the interpreter to prep them and get their input on how certain difficult topics should be relayed. Thank you, Nosley. You're giving a preview into what we'll be talking about. But for those who aren't from Harborview, cultural mediators are people who have interpretation backgrounds and continue to be certified interpreters, and then also have additional training and time dedicated to really getting to know families as like individuals and like what their specific values are, and helping them to learn about and navigate our complicated and often and very like Western and often unfortunately racist healthcare system. And so for people from Seattle Children's, for example, it's kind of the equivalent of our cultural navigators. Perfect. Thank you, everybody. And so I think the other big barrier or reason I see people not use a professional interpreter is because of family preference, that they say, oh, well, the family doesn't want to use they want to interpret. So like, I feel like I need to do it. And I think the first thing to say is that like legally we should, and the best case or kind of the gold standard care, I think, for families is for us to use a professional interpreter for every single interaction. And I kind of like to make but that just also brings to mind, I used to work in the diabetes field before medical school, and I would go to conferences, including some for kids with type 1 diabetes in their family. And at one of those, there was this professional football player who had type 1 and was talking about like giving himself insulin shots, like through his football jersey on the field. And a pharmaceutical rep like stood up and like interrupted him, was like, everybody, like, I need you to know that like that is an off-label way to give yourself insulin. And the football player responded, life happens off-label. And that's always been a line that's kind of stuck with me. And it comes to mind for me in this context in particular, because I think on-label is that we should be using a professional interpreter and not family for every interaction we have with a patient or anybody in the healthcare system who speaks a language other than English. And then I think off-label, at least for myself, is that the reality is that if I'm dropping off a coffee or just doing a brief like social visit and a family has said that they don't want a professional interpreter, I'm probably not going to be going heavy on them about bringing a professional interpreter into that encounter. But I think when we think about like a lot of the conversations we do have as palliative providers, it is really important, off-label or on-label, to have a professional interpreter. So I really love this paper by Schenker in the Annals of Internal Medicine, where she goes through like what are some complicated situations for in the medical system with regards to interpreters, and has like specific call out regarding when it's patient's choice is to have family and like when should we not be following that choice. And she specifically highlights like when the medical situation is too complex for the ad hoc interpreter to understand or translate, or the patient does not feel comfortable discussing sensitive information with the ad hoc interpreter, or the ad hoc interpreter experiences substantial role conflict, and as well as these other ones that you can read here. And I think that in my mind, this really applies to just about every palliative care conversation we have, other than your very brief, like dropping off a coffee to say hi moment. And so I think that like on-label or off-label, we really have to be using professional interpreters for all of our conversations and figuring out ways and systems to make that happen. And so like, what can you say to a family that is saying like, I want to interpret myself, I don't want to use a professional? And so this is language that is based off of that article, as well as conversations with Harborview and Seattle Children's interpreters, but saying like, I really appreciate your help with interpretation, but I fear I am not doing a good job of understanding. So trying to take the burden is on us and the fault is on us, not on them in terms of the quality of their interpretation. And I would like to ask a hospital interpreter to assist us in addition to you. So kind of highlighting that just having a professional interpreter doesn't mean that the family can't continue to interpret to some degree. But that at least we'll have a professional there to help them and to kind of provide backup as needed. And then so that I may provide better care. And so you can focus on supporting your family. So really reminding them too, that the thing we really want them to be focused on is supporting and loving their family rather than interpreting. And I saw Melissa in the chat, any communication recommendations for families, framing interpretation for families? Okay. Yes, so this, thank you for that question. And this was the suggestion, the suggested language I have here, thank you. The other piece I'll say is that in talking at least to the Seattle Children's Interpreter Services, they also said like they like us like starting with this language, and then if a family were to continue to oppose the use of a professional interpreter, that they're at a place, at least as that institution with their risk team, of saying like it is like illegal for me to do this conversation without a professional interpreter present, and to like really hold that line for especially like these critical conversations. And the other thing I think is important is to, when a family's declining a professional interpreter, is to talk to them about why. I think what I've noticed this year is that we often have patients who, of course, have intersecting identities. And some of those identities can be at play when they are feeling unsafe with a professional interpreter. So like one poignant example we've had at Children's is some of our families who speak Ukrainian have told us that some of our Ukrainian interpreters, especially telephonic, are actually from Russia. And like in the team's presence, without us having any idea, those Ukrainian speaking interpreters from Russia were saying harmful things to the Ukrainian families in Ukrainian. And so once we knew that that was happening and that this was a like intersecting identity that was having that was at play, we were then able to work with our interpreter services to ensure that for our Ukrainian families, we were using interpreters not from Russia. And some other best practices is to pre-huddle with your interpreter, like Nazli called out, to define roles of team members, and then being extra mindful in the room regarding our communication choices and debriefing with the interpreter afterwards. And we'll talk about these in some more detail in a moment. So for the pre-huddle, like I think the agenda for this really is to talk about the specifics of the case. There's institutional variation on whether or not interpreters can access a patient's chart. So at like Seattle Children's, the staff interpreters can see a patient's chart, but all of our like telephonic or agency interpreters who come in can't. And then my understanding at Harborview is that the interpreters who are not also cultural mediators, they cannot see the chart, but the cultural mediators can see the chart. So I think it's just important to hold in your mind for any time you're working with an interpreter that they probably do not know any of the specifics about the case or really maybe anything at all. And so it's important for us to brief them on the background. And then also to like kind of tell them what are the objectives for this meeting, to talk about the terminology we're going to be using, since we know that we often use complicated terms that don't easily translate, as well as if an interpreter has worked with a family before, it's a great opportunity to get their perspective on what has worked and not worked in communicating with this family before. And then as well as it's really important that we define our roles and what we're asking the interpreter's role to be in that conversation, which is an important enough piece that I'll talk about it in more details in a couple moments. And I think part of why I've always like wondered about doing these is like also because they're time consuming, and I know our interpreters are really busy. So I always like would have feared like forcing something on an interpreter they don't want to do. But when we look at this survey of interpreters, the vast majority very badly want us to be doing pre-huddles, and there's only 5% who are either neutral or disagreed with the occurrence of a pre-huddle. So it's really something we need to be doing. And Nuvis, who's a cultural mediator at Harborview, gave me permission to share this example and like her perspective on why these pre-huddles are so important. She had this really poignant line of, we are humans, the things we say impact us, and we need to be prepared for it just like you. You know what you are going to be saying, but I can't read your mind. And then she went on to describe to me how 15 years ago, when she was an interpreter before she was a cultural mediator, she was called in overnight to interpret a conversation, and that there was like no pre-huddle or any briefing given to her ahead of time, and that like partway through the conversation, she realized she was like interpreting for a family that was finding out that their loved one had been assaulted and raped, and she felt like she had a like physical traumatic reaction to that, of her throat closing up and her not being able to speak as a result. And it was just really powerful to hear her describe it 15 years later, and how it still is something she carries with her, and how she felt like that situation, though it would have always been really hard, would have been substantially better if she'd had some time to prepare herself for the experience. So I'd love some like real world tips from you all on how you all are integrating pre-meetings into your day. And one of the things I've seen that I love about my fellowship and getting to go to different hospitals, that I get to see how different places do it. And one of the things I have really appreciated that they do at Harborview is it seems to be really the norm for the interpreter to be present at the kind of provider pre-meeting, which makes just so much sense when you're thinking about the purpose of that meeting, and the interpreter having the background that they need and the opportunity to ask questions of the team before they're then asked to interpret what's often like a very complicated conversation. And I will say, like, talking to like Seattle Children's interpreters, where that's not our standard practice, they also shared that at Seattle Children's, the standardization of the occurrence of a pre-meeting is a major priority for our interpreter team, given how important they see them being. And so they seem really open to coming to pre-meetings and wanting to be invited to that. And at least if it's like expected to be a very, very long provider pre-meeting, at least having 5-10 minutes set aside before the family comes in to brief the interpreter. I'm just curious if there's anybody else who's found ways that make this particularly effective, or things you like to make sure you cover during the interpretation. Okay, let's see. I've got Crystal says, it's been hard to have pre-meetings and warn interpreters about hard conversations when in-person interpreters are not available, especially if the language or dialect is rare. Yeah, this is, I think, a really big one. I think one of my ideas moving forward, and that I've started to see done and then going to continue to work on, is trying to, like, at least at Children's, we often have our interpreter stand, that are like little iPad stands that are like in the room. And I think I'm going to try and make it a standard practice to like actually go in, like see if the family is like ready to see us, and then pull the interpreter stand out and do the like huddle or debrief in the hallway or one of our quiet rooms, which I think is going to be like, I will acknowledge is going to be awkward. And I think is not as awkward as what we're like, as maybe not as bad as my gut feels, because one, often I'm like waving and then going back in the hallway anyway to like put all of my PPE on. And the other piece is that right now, what I have been doing of like waiting in the room to get the interpreter is also really awkward, as we like all stand there in silence listening to the ringtone. So I think when I hold in my head how awkward even the way I'm doing it now is, I'm going to try to make it a standard of bringing the telephonic or video interpreter out of the room to do a prep ahead of time. And in talking to interpreters, it sounds like it's actually even most important that we do the pre-huddle with our virtual interpreters, because they truly have zero access to like what is happening with the patient, or even the same amount of like visual context on what is happening. And in terms of like ability to like read the room and like see what the patient looks like in pieces like that. And I wonder if it'll also help some with the audio challenges and like the amount of repeating we have to do for them, if they have some sense ahead of time of what we're planning to talk about. But I agree that that is like the virtual piece definitely makes it harder for the huddle. Has anybody else found a strategy for working through the virtual aspect for the pre-huddle? No, it's a hard situation for us all. Okay. So I made reference earlier that one of the pieces of our pre-huddle is also going to be to talk about roles. And I wanted to go into more detail about it because this was an area of particular learning for me as I put together this talk. So when looking at that survey of healthcare interpreters, role clarity was the leading driver of an interpreter's impression of how well an end-of-life talk goes. So whether or not the interpreter felt clear about what they were supposed to be doing, and whether or not they felt like the medical professional or the provider knew what the interpreter was supposed to be doing, was like by far the most significant thing in terms of whether or not they thought the talk went well. And I think part of why this has been a topic for me to learn more about is because I had this impression until very recently that really all interpreters are doing is like verbatim or literal interpretation, which of course was kind of a naive thought I had, because as we've already talked about, a lot of terms do not have verbatim interpretation. So of course, there's always going to be some subjectivity in terms of the words they choose to use for that interpretation. But there's also other roles that interpreters have that are like included in their professional code. So one of those is to be a health literacy guardian, which is where our interpreters will help us to be our best selves when talking with families who speak a language other than English. English. So reminding us to give families opportunities to ask questions, potentially asking clarifying questions if it's very clear we just said gook. Or also sometimes there's reports in literature of interpreters modifying our language to be more well-spoken and friendly like we intend to be. So like one example is a provider being like, so do you get it? And the interpreter being like, was I clear? Is there anything I could explain? So just making us be our best selves. Additionally, and professional interpreters see themselves as having a role as a cultural broker, which is the language I've heard them refer to is like in medical encounters, there can be cultural bumps where a family's culture is in conflict or discord with our like Western medical culture, and that the professional interpreters see themselves as having a role of recognizing when those bumps are happening and helping the two groups to understand that bump and to navigate it. And I think that this cultural broker concept is one that I continue to noodle on in terms of how is it best integrated into our team, and a way to make sure that we are, of course, being culturally humble and thoughtful, as well as not being stereotyping at all in the way that we approach families. Because, of course, there's a lot of things that go into culture, and language is one window into that, but it's not the only thing. And the example that I really comes to mind for me in this regard is Meghan Markle and Kate Middleton, who are two women who speak the same language, however, seemingly based off the paparazzi and memoirs, have a lot of cultural differences in terms of like what they wear, whether or not they like to be hugged, whether or not they like to share lip gloss. And so I just think it's a nice reminder of, while our interpreters and ourselves can maybe learn some things about cultures, there's going to also be a lot of individual, family, and regional variations within that. And so always trying to be mindful and not make stereotypes, while also wanting to adjust our practices to a family's culture. And so what could it look like to define roles? These are some of my ideas. Is like during your pre-huddle, you could really specify with the interpreter when you want strict interpretation and explain some of your choices. So interestingly, I've heard from interpreters on both sides of like how sometimes we're so blunt and why are we so blunt? And then on other times, like, why are you all like so vague and so confusing? And so I think sometimes it could be helpful for us to share our work with our interpreters in terms of what our headline is and like, why are we choosing to be so blunt, or why do we have to be so vague in the context of medical uncertainty, as well as to get their feedback on, is that headline going to interpret well into the other language, or are there some adjustments that we should make for that? Additionally, this is a good opportunity to talk with the interpreter about their role in the room and how they can best advocate for the family. So inviting them to, in their room, clarify jargon that we use, or to provide cultural context. Like Nuvi advised that if an interpreter has worked with a family before, and so like has some personal interaction and data off of which to surmise some of their cultural aspects, they could, in this pre-huddle, the interpreter could share with you some of the cultural context and like how to navigate that in the meeting. Or if the interpreter's never met the family before, you can invite the interpreter to, like during your pre-huddle, and say like, hey, if you feel like there's a cultural bump happening in the visit, like please feel free to let me know, so that way we can like work through it in real time. Similarly, you can ask them to alert you if the family seems confused, and since sometimes some of that body language can be harder to recognize when you're working through an interpreter, as well as like that the interpreter can solicit clarifying information as needed, and that of course they can remind you to ask for family input and questions. And then in the room, we want to be particularly mindful with our communication choices. And so these are some of the suggestions interpreters had in that survey. And it's like speaking directly to the family and keeping eye contact with the family. So really trying to still center our provider patient or provider family relationship rather than looking at the interpreter, as well as like making sure we're being cognizant of using empathetic statements, since we know at least some of the literature suggests that we use fewer of those when we're working with an interpreter than otherwise. And similarly to be very mindful about and cognizant about giving time for questions, since the literature also suggests that we often don't give families as much time to speak or be a part of the conversation when we're working with an interpreter. And part of this also is being mindful to try and talk in short but complete sentences. So Dr. Lisa Van Cleef, she did this amazing study where she looked at how many alterations or errors did an interpreter make based off of the number of words in that utterance before the interpretation happened. And she found that the number of errors significantly increases, especially when there's more than 20 words per statement. And then Dr. Casey Lyon, who is a provider at Seattle Children's and does a lot of work around interpretation in medicine. She also advised the first level skill is to work on talking in shorter statements. And then the next level skill is to also be mindful around where you put your pauses in, because a pause has significant impact on the syntax and meaning of a statement. And so sometimes she's seen when people try to talk in shorter statements, they then add pauses for interpretation to occur that actually changes or makes confusing the meaning of the statement. So that's like the next level skill. And then it's also just helpful to like really keep eye contact, like intermittently check in with your interpreter around how much you're saying and whether or not they need more pauses, because they've also called out for me that like when we're using specific numbers or data, like that is like particularly hard to hold in one's working memory. So you then especially want to keep your statement shorter, but different people have different working memories. So like I said, some real world tips is during your pre-huddle, you can ask your interpreter to interrupt you as they need you to. You can also see if they like want to have like a little pause signal or something so that they can let you know that they need a moment. And then when somebody interrupts you, I think during that meeting and then afterwards, really expressing gratitude for that interruption and for them advocating for best communication for our patients. I think one of the things that I heard from interpreters and is like really borne out in the literature is that many interpreters often do not feel like they are a part of the medical team. And so it can feel scary or concerning to interrupt or to ask follow-up questions and things like that. So I think it's on us as providers and in our place on the unfortunate medical hierarchy to make sure we're being really mindful about how we react to when interpreters help us be better, to reinforce that their positive role on our team and our desire for them to continue to do those things in the future. Anyone else have suggestions on things they found helpful for talking in shorter sentences or statements when working with an interpreter? And then I think the other piece to be mindful of is our use of jargon or complicated terms. So the word I learned from interpreters for our complex medical terms is they call it high register medical terms. And some examples I heard for them are like things like bone marrow. Like one of the interpreters at Seattle Children's told me he was interpreting for a family that was like 2 years into their leukemia journey when he realized that they had heard the word bone marrow before, but didn't know what bone marrow was. And so really being careful with those things. That interpreter also said anything that involves genetics is high register and is something that we really need to like pre-explain and pre-talk through for the interpreter to feel confident that they're accurately translating it. Additionally, there's a lot of medical terms that are really vague and confusing in English and seem in many other languages to only become more confusing when they're interpreted. So an example is like stable, that I think often in medicine we find ourselves being like, oh, that patient on 3 pressors is stable because that's what they've been on for a day. It's like not worse. And so I think that's confusing in English, but then especially I heard from some of our Spanish interpreters that when they translate stable, it really takes on this stronger connotation too of like things are good. And so being really intentional around our use of that word and what we mean. And then there's also a lot of just jargon in palliative care that I heard from our interpreters. So Nuvi's talked about like how most likely is like really vague and feels like hard to interpret. And so her question was like, could we instead be like, we think X will happen? Or she also highlighted like for comfort that in verbatim Spanish, that is like comfort is like how a chair is comfortable. And so it really doesn't capture comfort care well. And so like instead talking about like really what do we mean? Do we mean less pain, less anxiety, rather than just a vaguer concept of comfort? Goals of care, I'll also acknowledge, is kind of a confusing jargon that's hard to interpret. And then I'm notorious for speaking with tons of idioms and metaphors that do not translate well, like bubbling up, next step, or on this journey. And so I'm curious if there's other words people have found themselves using that you like didn't interpret well, or strategies you've developed for avoiding saying them. I have been working on trying to talk a little bit slower when I'm working with an interpreter to filter out for myself the idioms I tend to use, but at the same time, trying to not talk so slow that it then comes across as like awkward or derogatory. So it's always a hard balance and is something I think I'll be working on for a long time, but curious if anybody else has found things helpful.
Yeah, Hannah, this is Elisa. I agree with you that what I have found when I am speaking in an interpreted conversation is that the amount of concentration it takes, kind of the levels on which my brain is functioning, is different than when I'm, speaking in English to a native English speaker, and I am sort of kind of pre-thinking about what I would say and then translating in my own mind before it comes out of my mouth into a simpler version of that. It takes a great deal of brain space and concentration to do it well, and it does require going slower. And similarly, I tried to come off mute before to talk about the 20-word thing, and I was not successful in my what I have to do in this setup, but the same thing is so true for trying to do 20 words. And sometimes in the moment that can be so hard. And so if there are like really critical parts of the conversation, I actually try to think about them beforehand, like the headline or some other aspect. And I will pretend like I'm a newspaper editor or a college professor, and I'll like redline it. I'll write the sentence like how I think it is, and then find words that aren't necessary and literally like edit it as in like how short can I possibly make this sentence and still convey the same thing. And that extra effort is sometimes what's required to make those word limits, and not easy, but it's that kind of, I've found that the more I invest beforehand, I sort of reap the dividends in the actual conversation.
Yeah. Thank you so much. I really appreciate that. And that also resonates so much. And I see Melissa in the chat wrote, yes, avoiding metaphors is so hard, especially on things that are terribly ingrained in our language that don't even feel like metaphors, like this path 100%, or like next step. I totally agree. It's just it's a challenge that we'll keep working on. And so then the last piece is to debrief after our encounter. So this is an opportunity to ask the interpreter their perception of how the family understood the conversation, their reflections on if there was anything we could have done better. It also, I think, is an opportunity to reinforce the important role our interpreters have on the team. And it gives interpreters an opportunity to have a space to process these challenging conversations with us, since like often we're about to go and process them as a team anyway. I think it's important that we start to include our interpreters in that space. And so this interpreter who is in Portland talks about having interpreted for a mother finding out that her baby in the neonatal ICU had died, and how emotional that was, and how then when she got called to interpret in the NICU again a week later, she felt more nervous about having to go through that experience again so soon. And she reminds us just of the impact having a series of bad cases can have on a person. And this is something I've also heard from interpreters, is like when they see that the order comes from palliative care, that can like have an emotional reaction for them based off of what they anticipate it might involve. And so I think this is an opportunity for us around our debriefs to try and help with some of that cumulative effect of these conversations on interpreters and ourselves. And I think part of why I had like hesitated to sort of do this before was wondering, like, maybe I'm not the person an interpreter wants to debrief, and I don't want to like kind of push that on them. And of course, we never should be forcing anyone to debrief, but I think we can see in the literature that interpreters really want us to at least offer the space for them to talk after the discussion. And so future directions, like how do we do better from here? So I think the biggest thing I see is that we like really just need more studies that center the views of LOE families facing serious illness. That study from the beginning with the quote from the father is the only study I have found in the pediatric or adult literature that looks at the experience or opinions of LOE families on the use of interpreters in palliative care. And so I think it's been really helpful for me to hear more from our interpreters, and I think it's just a big need for us to hear also from the families. Beyond that, some research ideas I think are important is like what has and what has not improved. Like there's some suggestions that we may be doing better with like empathic statements, but probably that needs like further elucidation beyond and just like Seattle Children's, and to make sure that is actually happening in multiple places. I also like continue to think about what are the best team roles for everyone to take in order to ensure we're providing the best care for our LOE families. Like there's some suggestions in the literature in some of the papers that feel it's more likely that we're not using as many empathic statements, that maybe we should be training our interpreters on like nurse statements and some of the like emotional recognition aspects of vital talk. And the idea being that maybe it's just not, we're not going to get to a place where an English speaking provider picks up on all of the subtle emotional cues that are impossible to interpret. And so maybe our interpreters should have some independence to respond to emotions on their own, to make sure, and then like communicate that back to the interpreter. Like, I don't know, but I think it's kind of an interesting idea to think about what is the best role for all of us and where we can be using all of our skills optimally. Additionally, I've been pondering what is the optimal pacing for interpreted serious illness talks. Like as a resident, I always was like, oh yeah, 10-minute rounds should just be 20 minutes when you're working with an interpreter. But it's very different, I think, when you're going from like a 1-hour standard palliative care consult meeting to 2 hours. That's a lot to put a family through. And I've seen some families like physically kind of wilt during the length of that hard conversation. And so wondering if like maybe there's other ways we should structure our time to make sure we're doing best by family. And then of course, we need to do more QI on how to access and utilize our interpreters. And I see in the chat, Melissa said, thanks for the call out on debriefs, Hannah. Debriefs with interpreters have some of the most meaningful ones I've had, perhaps because of the emotional bonds interpreters have with the families, and because the different perspective pulls us out of our medical mindset and has also pulled our team closer together. I totally agree. Thank you so much, Melissa. And so then these are also some ideas I have kind of like in my sandbox for like, how could we also just improve the structures of our hospital to do better for LOE families? One of that is like frictionless scheduling, kind of like Melissa called out at the start, and access to interpreters. I in particular have this dream of when a patient who in the chart has it indicated that they speak a language other than English, that there would be like an auto page to an interpreter of that language when an RRT or code was called for that family. because we know that those are important times for communication with families, but also are times that the medical team is really busy stabilizing the patient and so doesn't have time to go and hunt down an interpreter. Additionally, there's interesting thoughts around how do we adjust our nurse to patient ratios or like our team caps to ensure that teams are being given adequate time to work with interpreters and to provide effective communication to LOE families. And then I think that if it continues to bear out that pre-huddles and debriefs are important for effective communication with LOE families, then those should become a part of the standard practice of a hospital. And so I just also, given we've got a lot of people from different hospitals here, would love to hear if there's anything people are seeing work at their institution. I'll call out one thing I saw at UW Medical Center that I thought was really cool was it seemed like they have some way in their interpreter services system that they flag if a patient has palliative care following, and then those patients get like extra priority for in-person interpreters, which I think was just a really great way of acknowledging the importance of in-person interpreters and how some families like with their clinical context, like particularly need that in-person aspect for communication. But curious if anyone else has or things that you wish were present, like your auto page ideas. Okay, talk about it later. The other piece I'm interested in is how could we do better training, both for our interpreters around end-of-life care conversations. There's a couple pilots out there that look pretty interesting, but then also especially like what about for our providers in terms of how to work for interpreters? And I could not find any examples of trainings for providers and working with interpreters around palliative care conversations, which unfortunately is not a surprise because I think we're just doing a bad job regarding teaching medical providers how to work with interpreters in general. So there was a survey that found that 54% of pediatric residents have never gotten formal training on working with an interpreter, and 77% have never received any feedback on their use of interpreters, which unfortunately rings true to me in that I have never really had formal training on working with an interpreter, but fortunately I have now had the opportunity to get excellent feedback. And then I think the last piece is really thinking about how do we do better support for our interpreters to care for them as our team members and help them to have sustainable careers. And so a lot of that is, I think, conducting these post-visit debriefs, but I also heard from interpreters their desire to have some sort of like a tracking mechanism to notify them about how patients are doing, because they do develop these bonds and wonder about how they're doing in the future, as well as a way to let their manager know when a patient they've been following for a long time dies so that they can get some like extra support from their team. And then I also heard from interpreters at Children's and Harborview their interest in being part of like death rounds or other like more formal structured debrief opportunities to process these experiences. So this is just a huge thank you. I want to especially call out thank you to Nuvis, Luis, and Zan, who are interpreters that like somehow carved out time in their really busy days to share their perspectives with me. I also am really grateful for my mentors and year peers who gave excellent feedback to me on this presentation. And then, of course, a thank you to all the interpreters who've taught me on the fly, being one of those providers who hasn't had much formal training, as well as thank you to all of the palliative care teams I've gotten to be a part of this year, as well, of course, the patients and families who've welcomed me into their care teams. Thank you. And I think we've got a couple minutes left for conversation. And if anyone has questions or comments, or otherwise I have more questions I can pepper you all with. So that is a threat. Thank you, everybody. All right. Well, I'll go to my favorite question I had was favorite baby photo. I'll call it, the last one was my daughter, so that one's my favorite. The first one was also me, but that's my least favorite. Oh, Lisa Hudson has a question of how are death rounds initiated. So what I was referring to, like I'd say, first off, like in terms of this happening for interpreters, is I haven't heard of that being like a standard protocol at any of the hospitals, but what I was referring to is some of our teams and hospitals have set aside scheduled times that there is a formal facilitated discussion around hard patient cases. And what I was hearing from interpreters is their interest in either joining those conversations when they've had patients involved, or maybe what would be easiest to structure would be just to have their teams have like once a month or once every few months scheduled times with a debrief facilitator to get to talk about their hard patient experiences too. But I had heard from like the Harborview palliative care team that when they were sadly, due to the disparities with COVID, seeing a large number of Spanish-speaking families dying from or patients dying from COVID, that like Newbies or the Spanish interpreters were joining them for their scheduled remembrance time to be part of that debriefing experience. It's like one example too of how it's been intermittently done. Thank you, everybody. All right.